Meditation, Medications, your first psychiatric treatment. Today, we will discuss the number needed to treat. The physician, patient, and attorney need to understand the concept of number needed to treat. When doing research on psychotropic medications, hundreds of patients are examined for the reduction of symptoms of mental illness and for adverse side effects. The number of patients treated for one patient to show improvement is the upside. The number of patients for the patient to suffer an adverse side effect is the downside. This is not absolutely black and white for a number of reasons. During the therapeutic trial of a medication, there are many reasons to exclude patients from the study. The patients excluded will be among the patients that physicians will be treating in the real world outside the confines of a research protocol. There are many reasons for excluding patients from research before release of a medication by the Food and Drug Administration, the FDA. Experiments are not permitted on children because they cannot give consent, and it is unethical. Pregnant women are excluded. Patients with all manner of medical problems are excluded. All the excluded categories are patients that seek treatment outside of research facilities. In ordinary medical facilities, such as hospitals and doctors' offices, many patients offered the opportunity to participate in research before medication is released refuse to participate. All the patients who do not participate in research prior to release of a medication increase uncertainty. We do not know what the medications will do to the fetus, to the pregnant woman, to patients with severe medical conditions, and people who would refuse to participate in research. The use of medications in pregnant women, patients with severe medical problems, and with young children would be, in a sense, off-label and a continuation of the experiment without the constraints of an ethics committee in a control group and collection of data that would require termination of the experiment as unethical because of the emergence of serious adverse effects that obviously outweigh the projected benefits. What actually are researchers looking at? They usually are looking at a reduction in BPRS or PANNS scores. These are subjective measures of symptoms such as anxiety, agitation, and hallucinations. They are not measured by a blood test or an X-ray. A clinician observes a patient and says, "I think the score is 3 on a scale of 1 to 7. There is no way that two observers will give the same numbers in 15 or 30 different subjective measures. The research results are very fuzzy, gray, and not clearly demarcated black and white. Another factor to consider is that for research purposes, a 20% reduction in symptoms is considered barely perceptible, while a 40% reduction in symptoms is considered robust. The patient and family are looking at 100% reduction in symptoms. After taking the medication and finding out the improvement is a mere 40% with a significant side effect, the patient stops taking the medication. Is that noncompliance or a rational choice to stop wasting time and money on a treatment with costs that exceed the benefit? Another factor to consider is, what do you think when 50% of patients respond with a 20% to 40% improvement on the medication as compared to 20% of the patients responding to a placebo? The number of patients needed to be treated for one patient to be better would be about 3.33. This number for clinical purposes and risk management is rounded up to the next whole number, 4. Some patients might simply say, I want to wait and see if I get better without treatment. The analysis is similar for the number needed to treat to cause harm of some sort, the side effects. Thank you for your time and kindness. Tomorrow we will look at a clinical trial, the CATIE trial for antipsychotic medications, and consider the benefits and risks associated with that treatment and the study as a whole. Thank you for your time and kindness. Have a great day.